I may say good afternoon almost to you. I realize that it is against human rights to make you sit all day long here, but anyhow, this is the program. Yeah, the topic is complex aneurysm treatment. This is my disclosures. We were in a position in very early 90s to save some complex aneurysm treatment. The surgeons only giving us very complex basilar tip aneurysm that they cannot able to do it. Actually, we started with complex aneurysm treatment in very early periods, in 1994. At early 19s, we have only one material. It was detachable balloon to occlude the parent artery. That's it. But now, the world has changed. When you look the neck of the aneurysms, we can classify the aneurysm as a large neck after 4 millimeter, and giant aneurysm is above 25, and large aneurysm definition has some problem. We are not only occluding the sac, we are increasing the healing reactions and decreasing the regrowth rate. If you could not do it, this is not a treatment. One thing we should accept at the beginning, transition zone of the aneurysm is not known. We only see the enlargement of the vessels by some radiological imaging. As you see this case, this is aneurysm, this is coiling, and look at that, what's happening after it. All the segments turn out to be aneurysm, but it looks totally normal at the beginning in 1 month. So, the saccular occlusion is enough to have a good treatment or not? We improved a lot of things for saccular occlusion. We put bioactive materials, we put enlarging materials like hydrocoil on the coil. We even put radioactive coils in the aneurysms. But at the end, and totally, this strategy is occluding the sac. As you know, majority of the aneurysm is located at the bifurcation. So, even though you have a conventional coiling treatment for such aneurysm, wide neck aneurysm, when you observe it, a year after, there was nothing. Everything looks okay. But the 6 years later, look at that, there is something going on there. For what? Because when you look the hemodynamic pressure change in the bifurcations, and the so-called neck region had a constant hemodynamic stress, because occluding the sac are not changing any morphology in the bifurcation. Nowadays, we are using, I'm not using, but people are using web device. And then for web device, intrasaccular flow disruption, very fancy name, you can occlude an aneurysm nicely, and in 1 month follow-up, you can easily see that dog ears are still there. I have a big question mark in my mind to have a regrowth rates in those group. And then we started to create a nose of the coils with our improving technique, like this biballoon technique, like a ship nose or like legs of the bridge to divide the floor. But even in that position, we didn't have change too much pressure on the bifurcation. How can you treat this bifurcation aneurysm by coil? Because all the basilar tip diseased and all arteries coming off from the aneurysm. And those group, we have chance to use other device, and we first use the coronary stent, and then the companies realized that we need to produce the neuro stent for those guys, and they did it. We have different stents in our hand right now, and this is the treatment for this case. You are creating new vessels in the disease segment and using additional coiling for it. How can you treat this one? And the surgeons started to send that type of aneurysm to us. It's ACOM, no neck, practically, and then no surgeon wants to treat this one because of the problems of the reconstruction and the perforating arteries in that region. Look at that. And the aim was, I did this case in the live case course, the two bilateral approach, extenting and coiling. At the beginning, when you discuss the regrowth rate, forget about the operation risk. When you discuss the regrowth rate of that no-neck complex aneurysm, everyone said that it should be very high because you cannot occlude the dog ears. But when you started to play with the flow, this is the 6-month follow-up of this aneurysm. When you started, because the right flow goes to the left flow goes to the right by the help of stent. So there is no flow to the dog ears, so-called disease segment. And we improved ourselves by using other techniques. For example, that terrible angles, the branch of the MCA originating from the aneurysm with a different angle. Whenever you want to go the one branch, whole the system is changing its position, and it is really difficult to go the other one to create the Y stand, whatever technique you use. So we start to use the body wire as we used in carotid stenting or subclavian vertebral orificial stenting technique for MCA aneurysms. After using body wire, you have a good stabilization to create that Y configuration and then having good occlusion. But when you follow this group, you started to realize that this is the second year follow-up of this case. Even though you changed the morphology, you did a good coiling, there is still something going on at the neck. It is happening especially for very large and giant aneurysms. In small aneurysm group, the follow-ups are far better than the large one. I mean the more than 20 millimeter. The 10 millimeter for me is not large. I'm not accepting that classification. Another tools appears last years, this the P-conus, this the stent combination with some wires, that wires protecting the dangerous angles. And this is the P-conus, you can see it better in the down. And after coiling, it looks good. But look at the 1-year follow-up. Hold the aneurysm sac, filling again, all the coils displaced, and much importantly, the patient had a headache with a cerebral edema because of the pulsatility of the sac, and the patient under aspirin and Plavix. So that time we used a pipeline on the lower branch to change the hemodynamic totally. At the same time, we coiled that regrowth portion. After coiling it, this is the 1-month follow-up. Look at the reduction of the cerebral edema. We didn't give any steroid to the patient. just reducing the pulsatility effect, you can get such environment in the brain. I'm still following this case, with no problem. We realize hemodynamic effect is much important for complex cases. This is one of the case I realized it, and this is the isolated posterior communicating artery aneurysm. Patient came to me with a thalamic infarction. It's easy to coil it by losing the posterior cerebral artery. But at that time, I used the corner stent on the P1 and P2 junction. Look at the flow, how dramatic change in it, and then a coil in the orifice of the posterior communicating artery. No coil at all in the sac. So what's happened? In 6 months, intimal hyperplasia in the stent, aneurysm is still there but thrombosed. In 1 year, aneurysm start to shrink and the intimal hyperplasia reduction. This is the 5 year. Everything turned back to normal by using hemodynamic. At those years, they realized that hemodynamic importance in certain aneurysms. Like this, again, non-ruptured, but the mass effect with thrombosed aneurysm, and a tip aneurysm, comatose. And what we did, again, the coronary stent, and this is Onyx. At those years, we were using Onyx. And to prevent the perforating arteries, we stopped there. But look at that, what happened. After the stent, you changed angle of the siphon tip. And this aneurysm is not anymore a bifurcation aneurysm. This aneurysm turned out to be a sidewall aneurysm. And look at the healing reactions. The left anterior cerebral artery healing from the right side. Do you think it will recur? No. And we are still following this case. 15 years passed and still in good shape. This is first year follow-up. It is happening all treatment options. This the ruptured case is an old one, 1998. The surgeon wants to clip it, and they did a good operation, clipped and wrapped. No aneurysm at all. Everything looks normal. It's the 5 year follow-up. Something happening there, enlargement. This is the 9 year follow-up. Again, it's enlarging. This 14 years old, the patient started to have symptoms because of the enlargement of that fusiform segment turned out to be a saccular aneurysm with a fusiform neck. So at those years, we had good flow diverters for better healing reactions, better hemodynamic treatment. And this is flow diverter. And this is the combination with clip flow diverter and aneurysm. And this is the 1 year follow-up of these vessels. And we have now 7 years follow-ups of that modern flow diverter options. Still we are in good shape. And when you start to look the coiling and flow diverter group, retreatment rate is reduced down to the 3%. When you look at the coiling group, this is the main criticism of us. It is around 40. And also, procedure-related complication is not changed. We didn't increase that. But the complete occlusion rate is far better than coiling. Without problem, no. The main problem is the late rupture. We realized that whatever we did, even we had a loose coiling with such large aneurysm, we had late ruptures. And that late ruptures are really a big problem because majority of the patients are losing their life. Like this, relatively narrow neck. These are the first cases in the late 2000s. And even having a nice flow stagnation in the sac. We are creating a rapid thrombosis in the sac. That thrombosis eat the aneurysm wall and have a massive rupture, especially mostly in the first month. And they're not letting you do to retreatment again. And I published this one in early 2010. And then all of them, look at that, the size of the aneurysm is very large, relatively with narrow neck. So, after a while, the last year, the meta-analyses appeared. These are the late mortality and late neurological complication for flow diverters. It is around 3 and 1. And when you look to subgroup analysis of these complications, late ruptures and late ischemic strokes are more prominent in large and giant aneurysm and in posterior circulation aneurysm. And after having such complication, I changed my mind and I'm coiling it properly before putting flow diverter. For example, this patient has 6 meters of coil. Now it is, we have good chance to have a longer coil, 70 millimeter, 60 millimeter coils from the companies. It's good. And then after having total occlusion, I'm putting flow diverter in front of it to prevent regrowth, because we know that such huge aneurysm have a higher regrowth rate. And this is after. But time to time, you cannot occlude the aneurysm. This rupture MCA fusiform dissecting aneurysm, how can you coil it? Because of the lenticular striate artery. And no surgeon wants to do it. The only option for surgery is the bypass and occluding the M1 orifice. That's it. And we decided to do a dual scaffolding technique with Leo and Silk. Look at immediately after how dramatic change in the aneurysm, and the second month follow-up. And this is the 3rd year follow-up. He is still working in a factory by using his hands as a worker. Another one, ruptured MCA aneurysm. We were lucky because we are starting getting success. Look at the aneurysm itself. How can you treat this one? It is hardly understand where the upper truncus originating from. We found it, we did the flow diverter treatment. This is immediately after, and this is immediately after, and this is 4 months or second month later. Look at that. The aneurysm started to thrombose with a serpentine type of lumen reaching the distal part. Oh, so good. Now we're reaching our goal. Is it? This is the 4th month. Ruptured and died. So it is happening in that complex group, especially my most difficult group is the fusiform basilar aneurysm. Technically it is very easy, but the clinical results are not so good. Look at that, the fusiform aneurysm. We have a technique in our hospital to prevent compression effect after having thrombosis. We are opening a window in the occipital bone. We are putting shunt before giving aspirin and Plavix. And then after shunt and then having windows, we are putting flow diverters to reconstruct the basilar artery. Time to time we have very good results like this. But I was preparing this case last year for Buenos Aires WLNC course. I made the surgeon open the window, had a shunt, and I was about to prepare the patient with aspirin and Plavix, but while waiting, immediately after the operation, the aneurysm started to thrombose. No aspirin, no Plavix, just operation and shunt. 3rd day, and started to enlarge because of the thrombose and then rupture. Think about that. If I start to give Plavix and aspirin, and if I did the flow diverter in the course, and if it happened after the treatment, is that the complication of flow diverters? We obviously say that yes, it is the complication of the flow diverter, but it is not. This aneurysm itself has danger. We should accept so, with or without aspirin, with or without any treatment option. I looked the archive of mine and I found this case. It is an V4 segment huge aneurysm. At those years, 2004, we occlude the vertebral artery with the balloon. No flow in the sac. 1 month later, ruptured. No aspirin, no Plavix, nothing at all. Flow reversal, everything is there. And we rushed to the operating theater and we saved the case actually at those years, but this is a very good example on this group. Ruptured mid-basilar aneurysm, coiled. 2 weeks later, start to regrowth. Coiled and flow diverter. Good. We achieve our goal. We create the parent artery. 2 months later. Look at that. What is this? And another flow diverter to jet flow here. Very tiny area to jet flow. How can you explain this? This is the 7 months later. Without any ischemic region, we can able to stop this growth with another flow diverter. This is the 2nd year follow-up of this case. Another one, ruptured, came to us with a P1 bilobulated aneurysm, fusiform neck. First treatment 2009, telescopic 2 enterprise, no change. And second treatment, Leo and Silk, 4 stent together. And this is 4-year follow-up, no change, no aspirin, no Plavix, nothing. How can you explain this? This is, fortunately, at the 6-year follow-up, we occlude that upper part, but the lower part is still there. So, are we really understand which aneurysm is complex from the beginning? No. Just looking the morphology is not saying us this aneurysm is simple or complex. Thank you for your attention.